Pediatrics Neonatology Grand Round Series, hosted by the Pediatrics Center for Research, Education, Quality, and Safety. Before I pass it over to today's presenter, just a couple of quick housekeeping items. Within your GoToWebinar control panel, you'll find a handout containing the accreditation information for today's activity, including the relevant disclosures and objectives, and the brief biography for today's speaker. Following the presentation, we'll have a question and answer session moderated by Dr. Tim Biella, Pediatrics Neonatologist and Grand Rounds Course Director. Please feel free to submit your questions at any point during this webinar using the questions pane found within your GoToWebinar control panel. Within 24 hours of the conclusion of today's session, you'll receive an email with instructions on how to complete the activity evaluation and then how to access your CE certificate within the Pediatrics Continuing Education portal. Please feel free to email the CE team should you have any questions at continuing.education@pediatrics.com. We're delighted to have Dr. Bradley Yoder, neonatologist and professor of pediatrics in the Division of Neonatology at the University of Utah School of Medicine. As mentioned, his biography can be found within the handout section within your GoToWebinar control panel. So without further delay, I'll pass the virtual mic on over to Dr. Yoder to kick off today's session.
Thank you, welcome. I want to thank Dr. Reese Clark and Tim Biella for the invitation and the opportunity to present today. And I'd also like to give a shout out to Nicole Brenson and Cindy Chiappetta for their assistance in helping me put this together and get to where we are. So my only conflict of interest for disclosure today for this presentation relates to funding that I currently have with Preterm for some clinical research activities. My objectives are multiple. They're listed here, describing lung development at these pre-viable or early viable stages of gestation, as well as multi-hit injuries to lungs that will occur in this particular group of babies. To understand the approaches to early sustained lung inflation and the fact that they minimize ventilator-induced lung injury and optimize gas exchange. We'll do a brief review of some of the basic operative features of high frequency and conventional, and then we'll discuss some of the evidence for current approaches to early ventilator care. Now, I don't know if I should thank them for this opportunity. Ventilating the extremely premature infant in 45 minutes is an arduous task. There are thousands of citations, numerous chapters, clinics, symposiums, etc., that have been performed. I will try to cover as much as I can today, and it may seem like trying to drink from a fire hydrant, but it is only a trickle of information, and listeners are definitely strongly encouraged to review many of the terrific papers that I will cite during this participation. So, our interest in this topic rests predominantly with the fact that the most common morbidity associated with preterm birth is bronchopulmonary dysplasia. And though much has changed over the past 50 years since Northway and colleagues first described this problem, unlike most other morbidities associated with preterm birth, the incidence of BPD has not decreased, but has in fact increased over time. This continues to be a vexing problem for us. There are numerous prenatal, perinatal, and postnatal factors that contribute to the development of BPD. And two of the most important are topics for discussion today: very preterm birth and mechanical ventilation. So why is that? It is demonstrated on this particular graph, which shows our own unit ventilatory support by gestational age. And as you can see, once at 27, 28 weeks, there's very minimal exposure nowadays to babies in terms of mechanical ventilation. Most babies are extubated very quickly, if they're even intubated at all. However, there continues to be a high rate of ventilator exposure in babies born less than 26 weeks gestation, with median values of 30 to 50 days of mechanical ventilation. So this approach to mechanical ventilation, and in these babies, BPD is primarily occurring in the context of a canalicular stage of lung development, a very immature stage of lung development ranging from 16 to 26 weeks gestation, but a stage at which there becomes the ability to affect some gas exchanges. Now, there are very obvious and dramatic differences between the non-viable preceding pseudoglandular stage shown here on the left, where gas exchange simply is not possible, as well as the subsequent or proceeding saccular stage occurring beyond 26 to 28 weeks gestation, where thinning of the mesentery becomes significant, improved angiogenesis and vascularization occurs, and there is a significant gas exchange that occurs and can allow us to, in fact, achieve gas exchange effectively with very minimal use of mechanical ventilator support. This pictograph highlights some of these key changes. The mesenchyme, which is very thick in the pseudoglandular stage, begins to thin, though not as thin as in the saccular stage. Capillaries become closer and approximate the airways, though they're still not mature double capillary loop systems. There's clearly increasing airspace, and there is the beginnings, but not really true definitive septal formation. There's also initial differentiation of type 1 and 2 alveolar epithelial cells, and the beginning presence of surfactant, which can contribute to lung function. So lung development is highly orchestrated process, and there are significant changes that occur in gene expression across the entire span of gestation. This slide demonstrates some gene heat maps that show how there is a significant change in the up or down regulation of genes from early to late pseudoglandular stages to canalicular stages. And these continue to occur with gene upregulation and downregulation throughout the latter stages of gestation to help affect normal lung development. Now, fetal perturbations such as growth restriction and or infections may interrupt this normal developmental process, which also becomes significantly altered in the context of preterm birth. In an effort to better understand the pathophysiology of BPD, most lab models for BPD are limited to single insults and single interventions. However, in real life, there are multiple insults that contribute to neonatal lung injury and that promote progression in these preterm infants to bronchopulmonary dysplasia. Now, in this presentation, we're most interested in the impact on mechanical ventilation. And this gene heat map shows dramatic shifts in gene expression associated with only a few hours of exposure to low tidal volume mechanical ventilation in an otherwise normal rodent lung. And in this study, there were over 700 different genes that were differentially expressed with activation that was predominantly in the pro-inflammatory and immune-mediated pathways. You might imagine what happens in terms of the effects on gene expression and these immune-mediated pathways when a baby is exposed to not just a few hours of mechanical ventilation, but to days or weeks. This very exquisite study out of the lab of Dr. Bernard Thibault in Ottawa nicely shows the effect that even 21% oxygen, room air, disrupts human fetal stem cells and alters the activity and function of those stem cells that contributes to an interruption of normal lung development. So simply the process of being born very early and exposure to the relative hyperoxia of room air compared to fetal oxygen levels affects lung development. Additionally, infection, both choriodecidual infection or fetal exposure to infection, as well as postnatal infections, also affect changes in morphogenesis and angiogenesis pathways that lead to abnormalities of lung growth and development and contribute to lung injury. So, there's a brief interim summary from this first section. Important to remember that lung development is highly sophisticated, that at birth, most of these very preterm infants are in the canalicular lung stage, which is really just at the threshold of the ability to obtain effective gas exchange. And both preterm birth, the factors that contribute to that, as well as neonatal care practices, disrupt lung development and lead to impaired alveolization. Now, we've all seen pictographs, radiographs that look like the ones shown here, with significant atelectasis as shown on the left, and fairly good appearing lungs as shown on the right. I've attempted to provide a representation of what aeration of these lungs might look like if you could open the chest at the same time the chest x-ray was taken. And you can see that there is dramatic atelectasis and lung deflation on this left one, as opposed to really nice inflation of the lung on the right. Now, what we're trying to achieve is an optimal lung volume when we're managing our babies for a variety of reasons. But the main reason is because at that level of lung inflation, it's where matching of ventilation, perfusion, and pulmonary blood flow result in maximum oxygen uptake, but also maximum blood delivery, so oxygen delivery to the tissues through the effects that can also occur in the cardiovascular system. Achieving and maintaining optimal lung volume is a dynamic process, and one should not feel like once you think you've achieved it, that it's going to stay that way forever. So again, here are some radiographic examples of various relative lung volumes, low, high, and perhaps a more optimal appearance. Now, I don't really have the time to go into a very detailed explanation of the progression from low lung volume, high FiO2 RDS states to an optimized lung volume with low FiO2s, but we'll go through some of that in this particular slide here. There are references as noted here, but also some of the other references noted later in this presentation that also have descriptions of how those authors tend to achieve or try to achieve optimal lung volume through a lung recruitment process. Here, what you can see is that in this particular situation, they are starting at a relatively high FiO2, close to 70–75%, with relatively low lung volumes. So this is an underinflated lung that is not going to be effective at oxygenation. Subsequently, typically one goes up in 1 to 2 centimeter increments in mean pressure until you affect improvements in SpO2 oxygenation, and you can begin to wean FiO2, and you kind of continue to advance reductions in FiO2 along with advancements in mean airway pressure until you can get your FiO2 typically consistently less than 30%. If you have an FiO2 consistently less than 30% with good oxygenation, as measured by SpO2s, then you typically have an acceptable lung volume to operate at. In many practices, they will also begin to wean that mean pressure down, monitoring SpO2 and FiO2 until they begin to see a decrement in SpO2 and an increase in FiO2. And at that point in time, you've weaned the mean pressure to the point where you begin to allow that lung to begin to collapse or become a little bit more atelectatic. Oxygenation is impaired, and at that point in time, you move back up to a slightly higher mean airway pressure to try and achieve, again, that optimal mean lung volume for subsequent ventilatory support. Now, in the face of surfactant treatment, this whole dynamic still is present, but the pressures that are required are much, much lower. And these pressures are probably much more consistent with what most people operate under, where the mean pressures typically are in the 9 to 10 to perhaps 12 centimeter of water range when you're achieving your initial gas support with good oxygenation and FiO2s consistently less than 30%. Now, it was the ability of high frequency ventilation to gently recruit the lung, minimizing FiO2 exposure while achieving adequate ventilation using very low tidal volumes in surfactant deficient animal models and infants that created a huge interest in high frequency back in the late 70s and then over the next ensuing decades. Currently, with surfactant therapy, there may be more varied approaches to allow us to manage these babies, but the consistent need there is to have optimized lung volume, which also means to not have atelectasis or hyperinflation. So again, it's a very dynamic process. And how is it we can sustain oxygenation when mean pressure is lowered? Well, it's important to know that normal functional residual volume typically occurs at a level significantly less than total lung capacity. So over on the right here is the adult, but we're interested in the neonate, where the total lung capacity is approximately 60 mLs per kilo in this particular pictograph. And as you can see, functional residual volume is significantly less than that. And this is where we and the normal infant typically operate in terms of our approaches to gas exchange. Going above that begins to affect overall cardiovascular performance through a more inflated lung capacity. And going below that also causes problems with cardiovascular performance, but also with oxygenation. So at this normal FRV, or optimal lung volume, lung compliance is at its lowest, as shown on this graph. So changes in tidal volume require relatively small changes in pressure to occur. And additionally, pulmonary vascular resistance is at a nadir, so that the effects on pulmonary blood flow are maximized. So once lung recruitment occurs, studies show us that as mean pressure is reduced from this max pressure to open the lung fully downward, oxygenation is maintained because volume is maintained. And you're moving from this little volume pressure hysteresis curve over here, where you're moving back in pressure, but you still maintain a good oxygen volume. Now you want to try and come back down a little bit on that, and as you begin to drop into that, you begin to lose volume, and then you begin to lose oxygenation. But SpO2 tends to remain stable as mean airway pressure increases because the optimal lung volume is maintained. And it's interesting that you can drop that volume fairly significantly in terms of the context of normalized inductance plethysmography volume measurements. And I think this particular slide is just a wonderful representation of this process that I'm trying to describe with you, where you move from a poorly functioning lung that has decreased lung volumes, and as you incrementally increase that pressure, you begin to affect increases in lung volume. It gets better, you open the lung fully, and then as you wean that pressure back, this lung still maintains its open inflation status because of the changes of compliance related to that open picture. And then as you come back down, once you reach a certain point, you begin to again get atelectasis. So it's important to recognize that achieving optimal lung inflation during mechanical ventilation can also be achieved using conventional ventilation and optimizing PEEP levels. So similar to high frequency, inadequate PEEP compared to inadequate mean pressure contributes to lung dysfunction, gives you low lung volumes, whereas excessive PEEP and or excessive mean pressure lead to lung overinflation. And surfactant therapy will affect both of those particular approaches to care. So interim summary 2 is that optimal lung volume, best measured by O2 responsiveness, supports gas exchange and minimizes ventilator-induced lung injury. You have improved compliance that allows you to wean pressure at the level of optimal lung inflation, and you can begin to achieve this support, this lung level with both conventional and high frequency modes. But remember that there are ongoing inflammatory hits that continue to affect the injury, including the process of mechanical ventilation, exposure to oxygen, changes in nutrition, infection, that continue to mandate that we can monitor and readjust our support of mechanical ventilation to try and maintain optimal lung volume on a regular basis. Okay. So let's move into some of the aspects of mechanical ventilation, and there are multiple modes. We might as well introduce the elephant in the room at this point in time, and that is bias. We all have bias. We have bias in a variety of ways, but in the context of this particular presentation, although I'd like to think my own choices for ventilatory support are entirely evidence-based, the data is simply not there to make a claim that any one specific mode or support is clearly better than another. Where it does exist, I will try to provide the best evidence that is available, and we will move forward from here, understanding that I have my biases, you have your biases, and hopefully we can come to a reasonable conclusion at the end of this. Now, the two basic modes of conventional ventilation have been pressure limited and now more recently volume targeted approaches. Technological advances have clearly helped us develop the ability to use a volume targeted approach to ventilation, and this has become a more preferred mode for many people. And you'll note I use volume targeted most of the time. Sometimes there'll be a volume G, a VG, or volume guaranteed. it's never a volume guaranteed. It's always an attempt to try and achieve a specific target volume using, quite frankly, a pressure-limited approach to ventilation. So the advantages of volume targeting is that you get consistent tidal volume delivery. You have automated weaning or adjustments of peak inspiratory pressure as compliance improves or decreases. And you also can expect linear increases in minute ventilation as you make tidal volume changes or adjustments. And this slide simply shows the effect of that volume targeting approach, where the green line shows you that a larger proportion of breaths are contained within this 90 to 100%, 110% of set tidal volume with volume targeting, 80%, versus less than 50% during a pressure control mode. Okay. It's important to recognize that there are differences in both anatomic dead space in babies. Neonates in general have a larger anatomic dead space than adults. It's typically estimated to be about 1/3 of their total tidal volume is needed to overcome the anatomic dead space. It actually increases from term down to more preterm babies, as shown in this particular study. And what happens over time is that there are also additional functional or anatomic changes that may occur through exposure to ongoing mechanical ventilation that actually may increase that functional dead space, so that larger tidal volumes may be needed as one moves further along in the respiratory course of babies. At this point, studies out of Australia have been done to look at the influence of gestational age on dead space and measurements of alveolar ventilation in preterm infants ventilated with volume targeted approaches. And what the investigators basically demonstrated was that the tidal volume depends on a wide variety of factors, and they are both patient and device specific factors, and that there's not a specific target volume that can be used in every preterm infant, and that it must be adjusted to target physiologic rates, respiratory rates to be optimized. That is an unstudied hypothesis, and in point of fact, what tends to happen many times is that tidal volume gets set. It might be changed a little bit, but typically not a lot. And over time, what happens is we become more tolerant of mild hypercarbia as lung disease begins to manifest itself. And rather than increasing tidal volumes, they tend to remain fairly static until one moves into a more significant bronchopulmonary picture. What's the best mode for volume targeting? That's unclear. There are limited randomized controlled trials comparing different modes, and currently any one of these approaches could be used and could be advocated. And again, there's probably user bias that exists and preferences based on your experience and your respiratory therapist experience. The one thing we do know is that just using an SIMV approach is suboptimal, and that in order to maximize the benefit to the babies, one should probably use pressure support. In the context of using an SIMV mode, one could just use a only pressure support mode or an only assist control mode. But in the context of using just SIMV, increasing pressure support improves tidal volume delivery, minute ventilation, decreases respiratory rate, FiO2, and work of breathing. Now, there are a variety of things you have to keep in mind of when you're using pressure support. And I think one of the things that I see most commonly is that people may set a pressure support limit that is high and tends to create pressure support breaths that are often higher than the set tidal volume breaths that you're trying to achieve. So pay attention to where your pressure support is. I tend to target a PIP that's about 3/4 of the ventilator breath PIPs in order to not exceed set tidal volumes. But it's an adjustment that needs to be monitored closely in order to make sure you don't provide excessive tidal volume breaths as lung compliance improves with your pressure support breaths. So Fact or fiction? Volume-targeted approaches are better than pressure-limited modes for conventional ventilation. Well, the meta-analysis by Klingenberg in 2017, which looked at a large number of studies that compared volume targeting versus pressure-controlled, suggests that volume targeting is better. There is a significant reduction in BPD. There is a reduction in severe IVH. There's a reduction in air leak, in episodes of hypocapnia, and in days on mechanical ventilation. So, in fact, it does appear that volume-targeted SIV is the best mode for conventional neonatal ventilation, if that is a option for you. So, interim summary 3 is that volume-targeted approaches are preferred. Typical starting volume is about 5 mLs per kilo. It can vary by gestation and postnatal age, and simply being aware of that variability that exists may help you in terms of making changes to affect better gas exchange. There are no specific ventilators and no specific volume targeted mode that currently has been shown to be better than another. So what about high frequency? The suggested advantage is that it provides adequate gas exchange with much smaller tidal volumes, but there are risks in using it. The main two devices that we have in the United States are the oscillatory device, the Sensormatics 3100, and the JET, the Bonnell Life Pulse. They're not currently FDA approved. Our colleagues in Asia, Europe, Canada, New Zealand, Australia do have access to other high-frequency oscillator devices that also allow a volume-targeted approach to high frequency. And some of the characteristics are shown here by these particular devices. Again, oscillators predominantly have an active expiratory phase versus a passive expiratory phase of the jet. And this leads to differences in rates that are typically used in the support of babies with these modes. Most of the oscillators use a fixed IDE ratio. Currently, the most common ratio in the 3100A is 1:2, whereas with the Draeger, there are investigations or studies there where people use both a 1:1 and a 1:2 approach. Inspiratory time varies because of the effect of an IE ratio in the oscillators, but tends to be initially fixed at 20 milliseconds with the jet. There are some differences in peaked waveforms. A couple of major differences are that you can give conventional breaths as part of, in continuity with, or as part of your high frequency support with both the jet and with the Draeger and the other systems that are approved for high frequency ventilation use outside of the United States. And again, this is not an FDA approved device. Additionally, the Draeger, the Stephanie, and other systems actually also allow volume targeting during high frequency ventilation. Now, there's a couple additional features on the jet that's worth talking about. One is that it's wedded typically to a conventional ventilator, which is where you support your PEEP, which is the primary factor that drives your mean airway pressure, again, to optimize open lung volumes. When coupled with this standard ventilator, the set PEEP, as shown on the ventilator here, currently in this system is at 10, is what's set to be delivered to the med, but the jet actually measures its own PEEP. And changes or differences that are significant between the measured PEEP on the jet and the set PEEP on the conventional ventilator can be used to assess for inadvertent PEEP. So if this starts to creep up to 2 or 3 centimeters above this setting, you need to think that maybe you're air trapping and you need to reinvestigate the settings that you may be using. Additionally, there is a servo pressure reading which gives a relative estimate of system compliance and can be monitored, though there are really not any good studies to suggest what to do with this in the context of ventilatory support. So as that number rises, system compliance is improving, at least in the absence of any leaks that are significant in the system. I'm not going to go too much into ventilation, everybody understands that the tidal volume is a key component of how high frequency works. And importantly, all high frequency ventilators, there is a marked diminution of tidal volume and pressure that is delivered as the gas moves down the airway. Bigger ET tubes have less resistance to flow, and therefore larger tidal volumes can be delivered with larger ET tubes. And again, oxygenation is dependent on open lung volumes, and that's a difficult task to determine in babies who have relative lung hyperplasia disorders. But again, FiO2 consistently less than 30% in radiographic appearance can be factors currently used to assess that. In the future, we are likely to also employ lung ultrasound measure evaluations, as well as electrical impedance tomography to try and get a better handle on optimal lung volumes. So, does one high frequency mode have an advantage? What do the clinical trials comparing high frequency oscillation to jet show? They show this. There's nothing out there. Despite over 40 years of high frequency practice, there are no randomized controlled trials that have compared high frequency oscillation to the jet for any neonatal respiratory disorder. Well, what about trials comparing the ventilator, oscillatory ventilation to, or even jets to conventional mechanical ventilations? Really, there are much fewer jet trials that have been done, but there are a large number of high frequency oscillatory to conventional ventilation trials that have been done. So the question is, does high frequency lead to better lung outcomes than conventional mechanical ventilation when used early in the course of treatment, RDS in preemies? And the most recent review on this from a meta-analysis perspective was back in 2015 by Cools et al. They analyzed 19 studies that involved over 4,000 infants. And the single conclusion that's notable here is that the authors thought that there was a small reduction in the risk of chronic lung disease associated with high frequency oscillatory ventilation. And that's shown here. There's about a 14% decrease in the risk ratio comparing high frequency to conventional ventilation. But when one began to look at all the other factors that were involved in these studies, including the use or lack of use of surfactant, the lack of use with pressure control versus volume targeted ventilation, the lack of optimal lung volume strategies or the use of optimal lung volume strategies, the benefits of high frequency ventilation were lost. And there are a number of caveats to these trials that really need to be considered. First, early trials, which tended to favor high frequency, were done prior to the availability of surfactant replacement. Second, the majority of studies employed a pressure-controlled approach to conventional ventilation, and thus significant variability may occur if a more volume-targeted approach was used. Third, not necessarily all studies employed a open lung approach to mechanical ventilation, to high-frequency ventilation or conventional ventilation. And fourth, there was not an optimized approach to post-extubation non-invasive support. The last, and perhaps most meaningful for our discussion today, is that the mean gestational age is typically greater than 26 weeks gestation. In fact, many of the trials, the mean gestational age was 28 to 29 weeks gestation. And as presented earlier, many of these babies nowadays don't even require mechanical ventilation or only brief, short periods of mechanical ventilation, and it would be hard to necessarily assert that there would be significant differences in how one approached in that particular context. So the vast majority of babies that we're talking about today have not been involved in trials that have compared most approaches to mechanical ventilation, including high frequency versus conventional. And this again brings us back to this concept of bias. So, interim summary 4 is that high frequency has unique characteristics that must be understood to optimize performance. There are no randomized controlled trials comparing different high frequency modes to each other. And current meta-analyses and long-term follow-up studies, which I did not show you, do not show benefit for high frequency ventilation versus conventional. So let's talk about the babies. One thing to recognize is that there are common strategies in hospitals that show significant success in the care of the extremely immature baby in the 22 to 24-week gestation group. This includes both aggressive pre- and perinatal support interventions, written guidelines or checklists, early stabilization in the delivery room, and a standardized first intention approach to how they ventilate these babies. So in a recently published review that I highly recommend all of you read and look at carefully, investigators from Sweden, Japan, and the US who have reported on improved outcomes in their units for 22 to 24-week gestation babies describe some of the general approaches to care they provide. Universally, as I noted, they provide aggressive antenatal steroid interventions to try and mature the systems, including the lung of these babies. They commonly employ very small endotracheal tubes, 2.0 tubes in the delivery room. They provide early surfactant, early caffeine therapy. The area where there perhaps is the most difference in their typical approaches lie in their approaches to cardiovascular support and management of PDA. Now, interestingly, each of these successful centers uses a different ventilatory approach. The Swedish center from Uppsala uses a volume targeted approach, typically with assist control, with settings as shown here. They start with a tidal volume that's typically about 5 mLs per kilo with a PEEP of 4 to 5. They use a assist control rate of about 60 because that is typically where many of these babies operate normally. So they're basically trying to match the physiologic breathing mechanisms of these babies with a fairly short inspiratory time. The gas goals are all pretty similar in these groups. And though their goal is early extubation, their mean age at extubation is approximately 29 weeks. So it typically takes 5 to 7 weeks before they can effectively extubate many of the babies with this approach. Now, in the Japanese centers, the approach is different, and they use a high frequency approach that is volume targeted. So the system they have available to them allows them to use a volume targeted approach with an initial tidal volume set of 1 to 2 mLs per kilo, setting their initial mean pressure at about 12 centimeters of water, as they've found this to following surfactant therapy to be an effective mean pressure for achieving optimal lung inflation. Their frequency tends to be around 12 hertz with an IDE ratio of 1 to 1 using this particular system. And they routinely incorporate an additional 3 to 4 side breaths during their early ventilatory support with this mode. They, in contrast to the Swedish group, actually prefer to use a very delayed approach to extubation in this group of babies, with their mean age at extubation somewhere close to 36 weeks. And the US Center, part of this study was the University of Iowa, which has published a number of studies in this area. They prefer the jet, and their jet settings are shown here. Since they're typically using a very small ET tube with a 2.0 diameter, their frequency tends to be lower at 300. They use a fixed I time of 20 milliseconds and a PEEP of around 4 to 5. They don't routinely use backup breaths initially, but will incorporate small number of backup breaths to try to maintain adequate lung volumes as the development of lung injury begins to manifest itself over time. And again, their primary goal is reported to be no failure of extubation. So they have a mean gestational age at which they tend to have babies extubated, which is about 31 weeks. So again, this is somewhere around 7-8 weeks of age that these babies have been exposed to ongoing mechanical ventilators. Their overall goals, in addition to having good gas exchange, is to try and minimize volume trauma and to also minimize over-distension because of the adverse cardiopulmonary effects and cerebrovascular effects that may occur with that. Now, here's a brief description from the group in Sweden where they did a retrospective trial comparing their early pressure limited approach to their now volume targeted approach, comparing 2014 and 15 to 17 and 18. Both modes were used in an assist control, and again, most of these babies received antenatal steroids and surfactant therapy. They used a Stephanie or Sophie ventilator from Germany, and these are the settings. They're pretty similar to what I recently just described. What they found was that there were significantly lower peak inspiratory pressures in the volume targeted approach compared to the pressure limited approach. PEEPs, FiO2s, and respiratory rates were all pretty similar, and they were pretty close to their volume target that they were trying to achieve. Unfortunately, they did not present volume targets for the pressure limited ventilation because that was not available to them at the time. Now, interestingly, the tidal volume group also had less hypocapnia and had a greater proportion of babies who had an attempted extubation by 24 hours of age. It's unclear whether the earlier extubation represents a time-related shift in clinical practice or not, but despite the apparent early benefit of volume targeted and lower initial PIPs, in this particular study, they ultimately did not show differences in survival, BPD rates, days of mechanical ventilation, IVH, etc., between the two different epochs using two different approaches. Now, this is a study out of Spain, out of Madrid, and I'm showing you this because it brings to bear the concepts of using possibly high-frequency oscillation with a more volume-targeted approach. And this is in a slightly larger sample of gestational age group, and it's a pilot study, but the goal was to assess the efficacy of higher frequencies and lower tidal volumes in trying to achieve targeted PCO2s. And here's a pictorial of the baby log VN500 that they were using. It's important to note that they can give sigh breaths, and this is what a sigh breath looks like in this particular system. And there are brief pauses in high frequency breaths when a sigh breath is given, unlike the jet, for example, where if you give a sigh breath where the peak pressure does not exceed the jet's peak pressure, you will continue to get jet high frequency support on that conventional breath. So as you can see, they have the ability to set a tidal volume, to set mean pressures, I to E ratios, frequency, etc. And then they also have the ability to measure the delivered tidal volumes as well as the amplitude that is required to deliver that particular volume. So what they found was that, not surprisingly, as they increased the frequency of breaths that were being used, going from approximately 6 to 8 up to as high as 18, they had a marked reduction in tidal volume that was needed to achieve the effective ventilation targets that they were looking for. Now, most of these tidal volumes in the 2 to 5, 2 to 3 range exist in the 6 to 10 hertz range, and these are consistent with values that are reported from other high-frequency devices. So they demonstrated that even at these very high frequency rates, 18 hertz versus 11 hertz, and tidal volumes that were much lower at 1.5 versus 2.1, they actually had improvements in oxygenation and ventilation, as with reductions in FiO2. The correlation didn't necessarily exist with either the tidal volume or the frequency alone, but it's with the combination of the parameters that were set. So this essentially begins to move into a situation where they might be giving vibratory CPAP with improvements in gas exchange occurring via ultra-low tidal volumes at very high frequencies. Clearly, this warrants further investigation. And again, this is not a device available to us in the United States, but perhaps in the future, we will have the ability to use such devices as well. So what about the jet? This is the Iowa review from Jonathan Klein and his group where they've been using the jet for quite some time as their initial standard approach to these very small babies. And again, they use a standard 2.0 ET tube for many of the babies less than 24 weeks. Their initial jet settings are shown here, and again, they're very similar to what I showed you on the previous slide. Low rates, typically around 300 if a 2.0 tube is in, moving to 360 if the tube is 2.5 or higher. Eye time tends to be fixed at 20 milliseconds, and they do not move that up or down. They have significant concerns to try to minimize air trapping, which is why both of these particular parameters are set where they are. Their PEEP is typically set around 5, and again, the goal is to avoid either under or over inflation. And they begin to monitor and increase PEEPs in relationship to both core inflation on radiographs and FiO2s that exceed 40%. I should go back there. There are conventional breaths associated with that, but that's not necessarily added routinely, and so I'll just leave that on there, and you can look at that at a later time. Now, they nicely describe changes in ventilator support from baseline at 6 to 12 hours and 7 days in pre-extubation periods, which is typically several weeks down the road. And as expected, over the first week, there were some increases in jet PIP, FiO2, and PCO2. So these are manifestations of developing lung injury, evolving lung injury, which we see in all of these babies. But their approach is to use sustained jet support over many days and many weeks with extubation of infants, typically directly from the jet to non-invasive support. Now, it's important to note that the age at which they attempted their first ET tube change of this 2.0 tube was approximately 4 weeks of age. So they left it in for a significant period of time with a range, quartile range of somewhere between 3 and 5 weeks. Their first attempted extubation is somewhere around 7 to 8 weeks, with successful extubation occurring somewhere around 10 weeks of age. And again, a large proportion of their babies were successful with the first extubation at this particular time point. So, an improving survival and respiratory outcomes is occurring for very immature infants. Management via both volume targeted, high frequency oscillation, and high frequency jet ventilation, targeting optimized lung inflation approaches and low volume targeted approaches appears to be successful. No specific ventilator mode or tidal or volume targeted mode has necessarily been proven better than another, but there are not randomized controls. These are observational descriptions. So I think evidence from randomized controls as to the optimal approach for ventilatory care of the very immature infant is lacking. There's clearly evidence from centers with good outcomes in this very high-risk group of babies that a variety of modes, including volume-targeted, high-frequency oscillation, and high-frequency jet, can be successfully employed. This suggests that perhaps the most important factor contributing to ventilator success in these high-risk babies is the operator of the system and not just the device itself. So in conclusion, lungs of most preterm, very immature infants are in the canalicular stage at birth. There are multiple pre- and postnatal insults that contribute to the disruption of lung development and create injury and lead to the subsequent development of bronchopulmonary dysplasia in almost all of these infants. Adequate ventilator support can be achieved using conventional ventilation, predominantly via volume targeted approach, as well as high frequency modes, including oscillation and the jet. Given the very low numbers of these babies across multiple centers and the existing bias, although randomized controlled trials would be lovely to have, they are going to be very difficult to obtain, and we may have to just work under the context of best demonstrated practices approaches rather than a true best evidence approach to care. Thank you, and I will be happy to answer questions.
Hey, Brad. Hey, this is Tim. Thank you so much for giving us a presentation today on this important topic. So, can you hear me, Brad? Just to make sure.
I can hear you. Yes.
Oh, perfect. So thank you again. And so one of the questions came through, and there's been a couple of questions regarding percussion air VDR high frequency ventilator and its use and ability in the NICUs regarding, the kind of the percussive CPAP or vibratory CPAP that it can provide. Any comments or thoughts on it?
My comments would be, A, most people don't have a lot of experience with it. B, it is a powerful device, and so one has to be quite careful when using it, particularly in small babies. Our transport teams are really very good at using the bronchitron device. We use the VDR4 in our unit, but we typically defer to. We don't routinely use it in most cases of very preterm infants unless we have significant concerns with plugging physiology. I would say we rarely use it in our very preterm babies. This is more commonly used in our bigger babies if we're going to use it.
Perfect. Do you know, regarding the Draeger and the use of the VN500 high frequency, do you know, is that going to be under review by the FDA, or is it currently under review?
I believe it is under review, but I don't know anything related to that process at this point in time. So again, hopefully it would become another available device for us to use. I think a lot of studies would need to be done. I'm not sure of the overall power of that device. For example, would it be capable of, ventilating a baby with severe meconium or ARDS at 3.5, 4 kilos? I don't know that, because the studies that have been predominantly done in babies who are of smaller gestational ages and lower birth weights.
Perfect. Lots of questions about ventilatory guidance or management thoughts. Any thoughts about NAVA regarding these babies? NAVA appears to be a lovely device. Again, it's one of those devices not every center has an access to. I think people who do have access to it, like Howard Stein and his group in Toledo, the group in Akron, there's a variety of centers around the country who use it quite regularly. It has, I think, very good studies supporting the feasibility to use it in preterm babies. We don't have adequate randomized trials or trials in general. I didn't present that here simply because there's not really a lot of information on that specific device in the context of these really small babies that's been published. Again, most of the trial studies are a little bit bigger, and most of them are not prospective randomized trials to this point in time. I think it's a good device. I think it has a role somewhere in line with managing these babies, but I don't know that exact role at this point in time. We're going to be part of a study that has now been initiated looking at that particular device in a non-invasive context to try and get a larger randomized trial for the question of how do you manage the baby once you pull the tube out. But I don't know of anybody who's actually in the process of trying to do a study with it for intubated babies at this point. It may be out there. And it seems like in a lot of these papers and everything, everybody looks at gestational age mainly. What role do you think birth weight has in it? Because, in certain areas, like South Texas, we have a higher population where babies are immature, but they weigh more. Yeah.
Birth weight has a big role, I think. I think gestation is a better index marker of what the lung development is like. But the ability to ventilate, to get a breathing tube in is certainly affected by how small the baby is. And the one paper I referenced there from
The group at Iowa was actually related babies less than 750 grams. So the smaller the baby, the more difficult perhaps it is to manage just because of airway management issues. And clearly there are issues with the effect of growth restriction, intrauterine growth restriction on lung development and lung function. Although it tends to be, I don't know that it's an acute problem as much as it's perhaps a longer term problem in terms of the risk for vascular disease and or BPD. But they definitely go together. The smaller a baby is at any particular gestational age, the worse their outcome is. And so if you move to larger babies at very small gestations relative to smaller babies at very high gestations, they kind of begin to equate with each other. So they both are important. I don't know that one's necessarily more important than the other. That's a tough one to answer.
No, I appreciate it. And so on these conventional ventilators, when you're measuring tidal volumes in the tiniest babies, how accurate are they in the use of the flow sensors? And if so, do you think there's one out there that does a little bit better?
They're actually pretty good. There have been comparisons between the flow sensors for the ventilators is compared to standalone monitors, and they tend to be really pretty reliable. There's always going to be a little bit of an error, but one of the problems that occurs is that we manage babies with uncuffed tubes, and so there is always some loss of volume that it can possibly occur, and there may be larger percentage losses of volumes, and these systems are designed to kind of measure what goes out, what comes in, and calculate a relative proportion of volume that is lost, and then make adjustments in their delivery of pressure to try and provide the next breath. I think they're pretty good. I don't know that anybody has shown one particular ventilator better than another. I think Robert de Blasi and his group have looked at that in Seattle, and pretty much they were all pretty close to each other. So again, the smaller you get, the smaller the volume, the more potential error there will be just because of the relative effect of decreasing volumes.
Thank you. Appreciate that. And then a couple more questions. There's a lot of questions. So your topic has generated a lot of thoughts on this subject. When looking at the PaO2 levels, when making respiratory support changes, when you make respiratory support changes, are you entirely looking at PaO2s, or is it entirely based on SpO2s?
Well, I personally almost never look at PaO2. So the one thing I want to make sure I don't do is hyperoxygenate them. So I shouldn't say I never do. I'm not happy if PaO2s are, consistently above 80 or 100. But I tend to focus more on saturations, and I will use those as my target guidelines for adjustments in oxygenation.
And then we'll do one more question. One of the questions was, if you look at the studies, as you can imagine, increased vent settings after about a week of being intubated. Do you ever see a role of a late dose of surfactant a week out in some of the smaller babies?
Well, we do not routinely use that in our centers. I don't believe there's really good evidence supporting that as necessarily beneficial, and there certainly isn't, not that I'm aware of any studies in this really tiny group related to that. It brings into question lots of other potential therapies that may be coming down the road. For example, the use of steroid supplements with the surfactant, budesonide added to your surfactant, other anti-inflammatories added to your surfactant. If those were used as vehicles, that might be a benefit that could be used in addition to just their initial use up front. And there's a large trial that's, I think, close to completion in Australia on the budesonide surfactant question, and the network has an ongoing trial with budesonide and surfactant. What is the role of things like IGF-1, which studies in the European community initially done to see if it improved ROP actually had a profound effect on what appeared to be BPD rates in that population. Those studies are being pursued. Additionally, stem cells and/or stem cell exosome studies are going to ramp up more. And so all of those things, I think, will probably play a bigger role in the future than perhaps going to something like a second dose of late surfactant.
Makes sense. Well,
I think
Dr. Yoder,
next decade is going to be pretty exciting for many of those potential therapies, and particularly because some of them may actually begin to redirect lung development pathways into an area that may improve overall lung growth and development, as opposed to what we currently do, which really does not have any positive effects on lung development.
thank you, Dr. Yoder. I mean, it was a great topic, great discussion, and so happy you were able to participate in our Ground Round series. And it's a little after 4, so I want to be respectful. So do you mind if people have more questions? Can they email you the questions themselves?
Oh, sure. I'm always happy to chat. Don't know that I have all the wisdom clearly, but I'm happy to chat. So
You have a great understanding of the subject, and we really appreciate you sharing it with us today.
thank you very much, Tim. I
Thank you.
appreciate the opportunity to talk.
Yes. So I appreciate everybody, and we'll talk to you all next month. Thank you all so much.